Good morning everyone. Today we'll discuss about one of the important tests to diagnose the neuromuscular junction disorder, that is myasthenia gravis, and sometimes it is also helpful to diagnose the another neuromuscular junction disorder, that is called Lambert-Eaton myasthenic syndrome. Okay, so I'll just tell you the history of this patient. This patient like presented in our neurology clinic with the complaint of the bilateral drooping of the eyelid, which is more in the evening time, and she has also history of difficulty in swallowing and difficulty in breathing. So on evaluation, we thought of the myasthenia gravis in this patient, and we requested her to do this repeated nerve stimulation test, which we are doing here at Grand International Hospital in daily basis. So what is the basis of the repeated nerve stimulation test? As you know, the myasthenia gravis is a disease of the neuromuscular junction disorder, and there is a blockade as well as the destruction of the acetylcholine receptor in the postsynaptic junction in the neuromuscular junction. So as you give the repeated stimulation of the nerves, so the release of the acetylcholine cannot increase the motor unit action potential of the muscles because of the blockade of the acetylcholine receptor in the postsynaptic junctions. So how we do? We have to prepare our patient for this test, and we have to choose the one of the muscles which is usually involved, that we can get that muscle from the history, but in day-to-day basis we choose for the spinal accessory nerve we choose the trapezius muscles, and for the axillary nerve for testing we choose the deltoid muscle, and for the musculocutaneous we choose the biceps muscle, and for the median nerve we choose the abductor pollicis brevis muscle here, and for the ulnar nerve we choose the abductor digiti minimi. And sometimes we also test for the facial nerve, and for the facial nerve we choose the orbicularis oculi and the nasalis muscles to test for the repeated nerve stimulation test. Okay, so which muscle to be tested, that we can get an idea by the history, but preferred muscle that we should do is the proximal muscle, and usually the trapezius, because it is quite easy and did not interfere by the so much of artifacts. But the easy one is the distal muscles. Like most of the time, if there is also the involvement of the distal muscles, then we choose the abductor pollicis brevis, which is supplied by the median nerve, and the abductor digiti minimi, which is supplied by the ulnar nerve. Okay. So after counseling the patient, we have to immobilize the hand, okay, because if there is a if the hand moves on giving the stimulus, then there will be artifacts. Okay, we have to immobilize the hand, and we have to first of all we have to do always the nerve conduction study, because we have to show that the peripheral nerve is intact to demonstrate the abnormality in the repeated nerve stimulation test. And after showing the peripheral nerve is intact, then we have to choose the median nerve, and we have to give the stimulus in near about 2 to 3 hertz, that is 2 to 3 stimulus in 1 second in the median nerve, and we have to record the action potential in the abductor pollicis brevis. So here we have given the like 10 trains here, like 1 2 3 4 5 10 trains, and on giving the first stimulus, this is the baseline compound motor action potential. You can see here the baseline compound motor action potential amplitude is 14.3 on giving the repeated stimulation, and this is second one, this is third one, this is fourth one, and this is fifth one. Usually in the fourth and fifth there is the most decremental in amplitude occurs. Like in the first there is 14.3, but if you see in the fourth it is 11.5. There is a decrement of around 22.8%. Okay, there is decrement of 22.8%. If there is the decrement by more than 10%, okay, more than 10%, then it is significant and is usually suggestive of the myasthenia gravis. Okay, so here is this patient shows the significant response to the repeated nerve stimulation test. Okay, so This is what we are supposed to do. And another thing what we have to do is we have to do even after exercise, like we exercise of the abductor pollicis brevis, like we can move the hands, okay, for near about 10 seconds, and immediately after exercise we have to do this test. And after 1 minute of the rest of the exercise, like I do this for 10 seconds, then I tested for this repeated nerve stimulation test, then give rest for 1 minute and again test for the RNS, then give rest for the 2 minutes, then again test for the RNS, give rest for the 3 minutes, then again test for the RNS, give rest for the 4 minutes, you can test for the RNS. That depends as per the time availability of the time. But the most important thing is that in the normal individual there is the post exercise facilitation, there can be increase in amplitude after you do the exercise, but in a patient with the myasthenia gravis there is constantly decremental response with the exercise. So there will be drop in amplitude even after you do the RNS immediately after exercise, or after 1 minute or 2 minutes or 3 minutes. So there will be the decremental response, and that value is more than 10%. So this is one of the most specific tests to diagnose the myasthenia gravis, but it is not that much of sensitive, because in general myasthenia gravis you will get this test positive only in near about 50 to 60% patient, and ocular myasthenia gravis, like it may not be positive. So okay, so I think you people know how we perform and how to interpret the repeated nerve stimulation test. This information will be useful for you people. Thank you so much.